Welcome back to the deep dive. Today, we are stepping away from the abstract and the theoretical, and we are walking right through the double doors of the emergency room.
hmm
We're talking about something that is technically a medical topic, but realistically, it's a high-stakes life or death scenario that happens every single day all over the world. We are talking about head injury, or to be more precise, traumatic brain injury.
It is a heavy topic,
Yeah.
literally and figuratively. But it's also a fascinating one because it sits right at the intersection of, well, physics, anatomy, and just rapid-fire decision-making.
Right.
You have these incredible forces acting on the most complex organ in the universe, and you have a medical team trying to mitigate that damage in real time.
Exactly. And just to set the stage here, when we say high stakes, we are not exaggerating. Head injury is a leading cause of death and disability globally. It's the kind of thing where seconds, not minutes, but seconds actually matter.
They really do.
And looking at the notes here, if you're a medical student or a resident, you know this topic is a favorite for high-level exams like the USMLE or the NEET PG.
That's right. And the reason it's such a favorite for exams isn't just because the anatomy is complex. It's because it forces you to prioritize.
Ah, okay.
It tests your ability to suppress the panic, look at a chaotic situation, and figure out what is going to kill the patient first. It tests everything from your understanding of how a car crash physically impacts the skull to the subtle signs that a patient is slipping into a coma.
So it's about integrating everything.
It requires you to integrate physiology, radiology, and surgery all at once. The key isn't just knowing the facts, but avoiding those exam traps and really understanding the specific algorithms for trauma.
So our mission today is to decode that expert approach.
Mm.
We are going to look at how the pros handle a head injury patient from the moment they hit the door to the decision to send them to surgery.
Mhm.
We're going to cover the airway, the neurology, the imaging, and the famous gonna-go decisions. This isn't just about memorizing a list of symptoms. It's about understanding the logic of survival.
We'll move systematically. We'll start with the physics, what actually happens to the brain during impact. Then we'll move to the bedside assessment using tools like the Glasgow Coma Scale, then to the imaging suite, and finally to the emergency management protocols. The goal is to move past just memorizing facts and really understand the algorithm of trauma.
I love that phrasing, the algorithm of trauma. It
What
sounds like something out of a spy novel, but it's actually standard of care.
it is.
So let's unpack this. Section 1 involves a core philosophy. When I think of a head injury, I think of the impact, the car crash, the fall, the baseball bat. But looking at our sources, there seems to be a huge distinction between the damage that happens then and the damage that happens later.
This is the single most important concept in neurotrauma. If you take nothing else away from this deep dive, take this concept. We divide brain injury into two distinct phases: primary brain injury and secondary brain injury.
Okay, lay it out for us. What distinguishes them?
Primary brain injury is the damage that occurs at the exact moment of impact. This is the concussion, the contusion, the tearing of tissue caused by the bat, the pavement, or the dashboard.
The mechanical damage.
It's the immediate structural damage to the neurons in the blood vessels. And here's the hard truth that every clinician, every surgeon, and every family member eventually has to accept. Primary injury cannot be reversed.
It's done.
It's done. The neurons are sheared, the tissue is crushed. No surgeon in the world can go back in time and undo the physics of that impact. There is no pill, no surgery, no magic wand that fixes the tissue that was destroyed in that millisecond.
Which sounds incredibly bleak. If we can't fix the primary injury, what are we doing in the hospital? Why are we rushing?
That's where the second phase comes in, secondary brain injury. This is the injury that occurs later, minutes, hours, sometimes days after the impact, due to the body's physiological complications.
Complications like what?
We were talking about things like hypoxia, which is a lack of oxygen,
Mhm.
hypotension, which is low blood pressure, edema, which is swelling of the brain tissue, and of course, raised intracranial pressure.
So, if I understand this correctly, the primary injury is the spark, but
Mhm.
the secondary injury is the fire that burns the house down.
That is a perfect analogy. The primary injury might kill a certain number of brain cells, but if swelling sets in and cuts off the blood supply, the secondary injury can kill the entire brain.
Wow.
And here is the aha moment for clinical management. While primary injury is irreversible, secondary injury is preventable.
That changes the whole game. It shifts the perspective entirely.
It does. It shifts the mindset from fixing the broken brain to protecting the remaining brain.
Mm.
The entire job of the medical team, the paramedics, the ER doctors, the neurosurgeons, is essentially damage control.
Okay.
We're trying to prevent the secondary injury from making the primary injury fatal. We're trying to keep the environment inside the skull perfect so the brain can heal itself.
So when we see doctors rushing around a trauma patient, hooking up oxygen and checking blood pressure, they aren't treating the bruise on the brain, essentially. They're trying to stop the brain from starving or suffocating.
Precisely. They are fighting a war against hypoxia and hypotension. Every single decision made in that trauma bay is filtered through that one lens. Will this prevent secondary injury?
Okay, so let's rewind to that initial spark, the mechanism. How does this trauma usually happen? What are the big culprits?
Unfortunately, the list is familiar. Road traffic accidents are huge cars, motorcycles, pedestrians. Falls are a major cause, especially in the elderly population where, balance is compromised.
Right.
Assaults, sports injuries. But what matters to a doctor isn't just what hit you, whether it was a rock or a floor, but how much energy was involved.
The high energy impact.
Right. We need to discuss the physics of the skull to understand why high energy is so dangerous. The brain isn't bolted down inside your head, it's floating. It is suspended in cerebrospinal fluid, kind of like a pickle in a jar of brine.
That is a vivid image.
It's accurate, though. And when you have a high-energy impact, say a car traveling at 60 miles per hour comes to a sudden stop against a tree, the skull stops instantly. But the brain, due to inertia, keeps moving at 60 miles per hour.
Until it hits the inside wall of the skull?
Exactly. It slams into the front of the skull. We call that the coup injury. Then it bounces back and slams into the rear of the skull, the contre-coup injury.
And I imagine that sloshing back and forth is not good for the delicate wiring inside.
It's catastrophic. This sloshing effect creates shearing forces. Imagine holding a block of gelatin and shaking it violently. It doesn't just bump the sides, the inside tears apart.
Wow.
In the brain, this causes something called diffuse axonal injury, or DAI. The long connecting fibers of the nerve cells, the axons, get stretched and snapped.
And DAI is strictly caused by this acceleration-deceleration, this shaking.
It is the classic cause. You don't even need to hit your head on anything. Just a violent shaking like in shaken baby syndrome or a high-speed spin in a car accident can cause DAI.
That's terrifying.
It is. And in these high-energy scenarios, you also have a massively increased risk of intracranial hemorrhage bleeding inside the skull, because those same forces tear the blood vessels.
Okay, so we understand the mechanism. We have a patient who has suffered a high-energy impact. They are wheeled into the ER. Chaos is everywhere. What is the very first step? I'm guessing, given we are talking about head injury, we look at the pupils or get a CT scan.
And that is the trap. That is exactly what your instinct wants to do. You want to look at the injury. But it is wrong.
Really? Why?
Because if you rush to look at the brain, you might miss the thing that kills them in 2 minutes. The brain can survive a bleed for a little while, but it cannot survive without oxygen.
Okay.
So the first priority in the primary survey is always airway, breathing, circulation. Specifically for us, it's the airway and the cervical spine.
The neck. You're worried about the neck before the brain.
Absolutely. There is an inextricable link between head injury and cervical spine injury. The force required to crack a skull is more than enough to snap a vertebra. So if a patient comes in with a head wound, the golden rule is you must assume a cervical spine injury exists until it is clinically ruled out.
So you're treating every head trauma patient as if they have a broken neck, just in case.
It's non-negotiable. You'll see this in the trauma bay. Someone is holding the head perfectly still, or the patient is in a rigid, hard collar. This is cervical spine immobilization. You do this while you are securing the airway.
And why is that so critical?
Because if they have a broken neck, and you tilt their head back to open the airway in the standard way.
You could sever the spinal cord.
Exactly. You could turn a brain injury survivor into a quadriplegic. So we use a special maneuver called the jaw thrust instead of tilting the head, all to protect that spine.
Speaking of the airway, there's a very specific number in our notes regarding when you need to take over breathing for the patient. A rule of thumb for intubation that seems to be a cornerstone of trauma care.
This is a high-yield rule for anyone in medicine to remember. We use the Glasgow Coma Scale, which we'll break down in a minute, to assess the level of consciousness. And the rule is simple. GCS less than or equal to 8.
If it's 8 or below.
You intubate. You put them on a ventilator.
Why 8? Why not 10 or 6? What's so special about that number?
It's all about airway protection. At a GCS of 8, a patient is essentially in a coma. They have lost the physiological ability to protect their own airway. Their gag reflex is gone. Their tongue loses tone and might fall back and block their throat.
So they could suffocate?
They'll suffocate on their own secretions, or even worse, vomit and inhale it into their lungs, causing a massive pneumonia. So GCS of 8 is the line in the sand where we say, we are taking over.
That's a very clear directive. So we keep mentioning this Glasgow Coma Scale, the GCS. It's famous. Everyone has heard it mentioned in medical dramas. GCS is dropping. But what actually is it?
It is the universal language of consciousness. Before the GCS, doctors used vague terms like stuporous or obtunded, which meant different things to different people.
Right. It wasn't standardized.
Not at all. The GCS allows a doctor in London to tell a doctor in New York exactly how awake a patient is, using just 3 components:
And those 3 components are?
eye-opening, verbal response, and motor response.
Okay, let's walk through them. Eye-opening seems straightforward enough. Are they looking at you?
Right. We score it out of 4. Do they open their eyes spontaneously as you walk up to the bed? That's a 4. Do they open only when you speak to them? Hello, can you open your eyes? That's a 3.
Okay.
Do they open only when you apply a painful stimulus like a pinch? That's a 2. Or do they not open at all? That's a 1. This tells us about the arousal system in the brainstem.
And verbal response?
We score this out of 5. Are they oriented? Do they know who they are, where they are, what year it is? That's a 5. Are they confused, like they think it's 1995? That's a 4.
I see.
Are they using inappropriate words, just shouting random nouns? That's a 3. Are they making incomprehensible sounds, just groaning? That's a 2. Or are they completely silent? A 1.
This tests higher cortical function. And finally, motor response. Can they move?
This is scored out of 6, and here is where it gets really interesting. The motor response is what we call the prognostic king.
The king. Why does moving your arm matter more than talking?
It is the single most important component for predicting the patient's long-term outcome. Eye-opening and talking can be affected by swelling around the eyes or, breathing tube in the throat. But the motor response tells you about the deep wiring of the brainstem and the connection to the body.
So what are we looking for? What are the scores?
Best case, a 6. They obey commands. Squeeze my hand. Wiggle your toes. A 5 is localizing pain. If you pinch their arm, they use their other hand to push you away. That's a purposeful movement. That's good.
Okay.
A 4 is just withdrawal from pain. You pinch them, and they just pull their arm back reflexively. But then we get into the really bad signs, what we call posturing.
Plastrum.
This is a reflex. A 3 is decorticate posturing. With a painful stimulus, they stiffen their arms and flex them up towards their chest like a mummy. It means the cortex is disconnected.
Wow.
A 2 is even worse. Decerebrate posturing. They extend their arms straight down by their sides and rotate their wrists out. That means the damage has gone deep into the brainstem. It's a very ominous sign. And a 1 is no movement at all.
So we add these scores up, eye plus verbal plus motor. The best is 15, the worst is 3. What do the totals tell us?
We classify the severity of the head injury based on the total score. A score of 13 to 15 is a mild head injury. A score of 9 to 12 is a moderate head injury. And a score of 8 or less
is severe, and brings us right back to that intubation rule.
Exactly. Severe head injury requires immediate airway control. You see how the assessment drives the management? Instantly.
Absolutely. Now, here's the tricky part about head injuries. Patients aren't static. A patient might come in talking and then go quiet. What are the clinical red flags, the specific signs we need to be watching for, like a hawk?
We call this the watch-out list. These are signs that scream emergency and suggest that pressure is building up inside the skull.
Okay, what's on the list?
First, obviously, is any drop in consciousness. If their GCS was 14 and now it's 12, that's a huge red flag. Second is persistent vomiting.
Not just throwing up once because you're nauseous or in shock.
No, we're talking repeated, forceful vomiting. It's a specific sign of raised intracranial pressure stimulating the vomit center and the medulla of the brainstem.
Okay.
Then a severe worsening headache. Not just a my head hurts, but an agony that keeps getting dialed up. Seizures are a major red flag. And finally, the most famous one, unequal pupils.
That's the classic flashlight test from the movies.
Yeah. If one pupil is blown, meaning it's large, dilated, and won't shrink when you shine a light on it, that is a mechanical disaster unfolding in real time.
What is physically happening to cause that?
It suggests that a mass, like a blood clot, is pushing the brain sideways. The temporal lobe of the brain starts to spill over the edge of a membrane inside the skull called the tentorium. As it spills over, what we call herniation, it physically crushes the third cranial nerve against the bone.
That is a terrifying image. The brain physically moving and crushing nerves.
It is. And it leads us to the golden rule of deterioration. Any deterioration in GCS is a neurosurgical emergency.
So if they were a 13 and now they are an 11.
You move fast.
Yeah.
You don't wait and see. It implies that a hematoma is expanding and taking up space that the brain needs. Time is brain.
Let's talk about those hematomas, the bleeds. The source material outlines 3 main types of intracranial hemorrhage, and they all have very distinct personalities, if you can say that about a brain bleed. They look different, and they act different.
They do. And recognizing them on a CT scan is bread and butter for any emergency doctor.
Let's start with the extradural hematoma, sometimes called epidural.
Right. Extradural means outside the dura. The dura is the tough outer covering of the brain like a thick leather sac. So this blood is collecting between the skull and that sac. The key here is the source. This is usually an arterial bleed.
An artery so high pressure.
Exactly. It's often the middle meningeal artery. It pumps fast. It strips the dura away from the inside of the skull bone. But here's the geometry part. The dura is stuck very tight to the skull at the suture lines, where the skull bones join together.
Like seams on a baseball.
Perfect analogy. So the blood can't spread past those lines. It gets trapped in one spot and bulges inward, pushing on the brain.
And what does that look like on scan?
Because it's trapped and bulging, it looks lens-shaped, like a biconvex lens or a lemon. Very distinct.
Now, there is a specific phenomenon associated with this one that sounds like something out of a horror movie, the lucid interval.
This is a classic exam question and a clinical nightmare. Here is the scenario. A young person gets hit in the temple with a baseball. The bone at the temple, the temporal bone, is quite thin. It cracks and cuts that artery.
Okay.
He gets knocked out for a minute from the impact. But then he wakes up.
He seems fine.
He seems totally fine. He's lucid. He says, I'm okay, just headache. He might want to go home. This is the lucid interval.
But inside.
Inside, that artery is pumping. The hematoma is growing bigger and bigger. But because he's young and have a healthy brain, his body compensates for the rising pressure until it can't. He reaches a tipping point.
And then he crashes?
He crashes. Suddenly, maybe an hour later, he rapidly deteriorates, a pupil blows, and he dies. It's the talk and die syndrome.
So the lucid interval is that deceptive period of calm before the storm.
Exactly. That is why we never trust a patient who says, I'm fine, after a significant knock to the temple without checking them out first.
Okay, that's extradural. What about subdural?
Subdural is under the dura. This is usually a venous bleed from the veins that bridge the brain to its protective covering. Because it's venous, it's lower pressure. It oozes rather than sprays.
And the shape on the CT scan?
Because it is under the dura, it isn't limited by those skull sutures. It can spread all along the entire curve of the brain. So on the CT, it looks crescent-shaped, like a banana or a sliver of the moon.
And the sources mention this is particularly common in the elderly.
Yes. As we age, our brains actually shrink, a process called atrophy. This creates more space in the skull, which stretches those bridging veins tight, like guitar strings.
So they're more fragile.
Much more. It takes very little force, sometimes just a minor bump or even a sudden jolt to snap one. So you see this often in elderly patients who had a minor fall a week ago and are now just acting confused or more sleepy. It's a much slower, more insidious process.
And finally, subarachnoid hemorrhage.
This one is different. This isn't a clot pushing on the brain from the outside. This is bleeding into the subarachnoid space, which is where the cerebrospinal fluid flows. So the blood mixes with the fluid.
That sounds bad.
It's intensely irritating to the brain. Patients often describe this as the thunderclap headache, the worst headache of their life, hitting instantly. On the scan, you see white blood filling the basal cisterns of fluid-filled pockets at the base of the brain. It can look like a white star in the middle of the brain.
So we have the lemon extradural, the banana subdural, and the star subarachnoid. But to see these shapes, we need a picture. We need imaging.
And the tool of choice, universally, is the non-contrast CT scan of the head.
I have to ask, why not MRI? We always hear MRI is better, more detailed, higher resolution. Why are we using the older tech here?
MRI is fantastic for detail, absolutely. We use it later on. But it has 2 fatal flaws in an acute trauma situation.
Which are?
First, it is slow. An MRI can take 30 to 45 minutes to get a good brain image. A CT scan takes seconds. Literally, you zip them through the donut and you have the answer. In trauma, we don't have 45 minutes.
Time is brain.
And second, MRI uses a giant magnet. If the patient is unconscious and has metal shrapnel or a pacemaker or we don't know their history, an MRI could be incredibly dangerous. Plus, all the life support equipment, the ventilator, the pumps, they're all metal. You can't bring them near the scanner.
So for acute head injury, CT first. MRI is for later, if needed.
CT answers the life or death questions. Is there blood? Is there a fracture? Do we need to operate? It answers them now.
But not everyone who bumps their head gets a CT, right? That would overwhelm the hospital system and irradiate everyone unnecessarily. There have to be rules.
Correct. We have strict indications, often based on guidelines like the Canadian CT head rule. Generally speaking, anyone with a GCS less than 15, so anyone who isn't fully alert, they get a scan.
Okay, that's a clear one.
If they have a focal neurological deficit like one arm is weak or their speech is slurred, if there are signs of a skull fracture like raccoon eyes, which is bruising around both eyes,
Yeah.
or battle sign, which is bruising behind the ears,
Right.
or, as we mentioned, repeated vomiting, or if they had a seizure, we're very selective.
Got it. So we've scanned them, we see a bleed, or maybe just general swelling. Now we move to management. We are in the ICU or the trauma bay.
Right. And here we loop right back to our core philosophy from the very beginning. Prevent secondary injury.
Damage control.
All of our efforts are focused on maintaining the big three: oxygenation, blood pressure, and intracranial pressure.
Let's break those down. Oxygenation seems obvious. The brain needs air.
The brain is an energy hog. It consumes 20% of your body's oxygen, despite being only 2% of your body weight. If you cut that off, cells die instantly. So we ensure adequate ventilation, keeping oxygen levels high.
But the second one, blood pressure, is where people get tripped up. The notes mention something called a hypotension trap.
This is absolutely crucial. You might think, oh, they are bleeding inside their head. Let's keep the blood pressure low so they don't bleed more. That logic works for a torn aorta, maybe, but it is deadly in head injury.
Why is that? It seems counterintuitive.
It's because of a concept called cerebral perfusion pressure, or CPP. Think of it this way. The brain is swollen, right? The pressure inside the skull, the ICP, is high. That pressure is pushing back against the blood, trying to get in.
It's fighting against the flow.
Exactly. To overcome that resistance and feed the brain, you need higher blood pressure, not lower. The simple equation is CPP equals mean arterial pressure minus the intracranial pressure. So if your blood pressure drops or the ICP rises, your perfusion plummets.
So if the BP drops,
The blood can't push its way into the skull. The brain starves. The data on this is crystal clear. Hypotension significantly worsens head injury outcomes.
Yeah.
A single episode of low blood pressure can double the mortality rate.
that is staggering. So you actually need to keep the pressure up to force blood into the injured brain?
Within reason, yes. We fight hypotension aggressively with IV fluids and drugs called vasopressors.
Wow.
We cannot let that blood pressure crash.
And the third goal, intracranial pressure, or ICP, the enemy itself.
This is the pressure cooker. The skull is a closed box. It has a fixed volume. It contains brain, blood, and fluid. The Monroe-Kelly doctrine states that if you add something new, like a hematoma or swelling, something else has to leave to make room.
But the brain can't leave.
Initially, your body compensates. It squeezes out some cerebrospinal fluid and some venous blood. But eventually, you run out of things to squeeze out. You run out of room. Then the pressure skyrockets.
So how do we lower it without surgery?
We have some medical tricks. We elevate the head of the bed to 30 degrees to help venous drainage. We let gravity help drain the blood out of the head. We ensure the patient's neck isn't twisted, which would block the jugular veins. And we use osmotherapy.
Osmotherapy sounds complex.
It's a clever idea. We use drugs like mannitol or hypertonic saline. These are substances that make the blood very salty or concentrated. By the laws of osmosis, this draws water out of the swollen brain cells and into the blood vessels.
So you're literally dehydrating the brain to shrink it.
Exactly. It buys us space, it buys us time. It can be a bridge to get the patient to the operating room.
And what happens if we fail? If the pressure keeps rising and rising despite all our efforts?
Then we enter the danger zone. The brain tries to escape the skull. We talked about herniation earlier with the pupil. But generally, when the pressure gets critical, the body gives us a very specific, desperate warning sign called Cushing's triad.
This is another famous medical triad. I recall learning this. What are the 3 signs?
Number 1, hypertension, very high blood pressure. Number 2, bradycardia, a slow heart rate. And number 3, irregular respiration.
Wait, I want to pause on that. That seems completely contradictory. Usually when my blood pressure goes up, like if I'm stressed or my heart races, why on earth does the heart slow down?
That contradiction is what makes it so distinctive. Here is the physiology, and it's fascinating. The pressure in the skull is so high that blood can't get in. The brainstem is suffocating.
Okay.
So the sympathetic nervous system triggers a massive adrenaline dump to spike the blood pressure. The body is screaming, push harder, force blood into the brain at all costs. That's the hypertension.
Okay, that makes sense.
But the heart has sensors baroreceptors in the neck that monitor blood pressure. They feel this massive pressure spike and they think, whoa, this is way too high, we're going to blow a gasket. So they send a signal via the vagus nerve to the heart saying, slow down, put on the brakes. That's the bradycardia.
It's a reflex trying to protect the heart, but it's fighting against the brain trying to save itself.
Exactly. It represents a physiological system in total chaos. And the irregular breathing is because the pressure is physically crushing the respiratory control center in the brainstem.
So if you see high BP, slow heart rate, and weird breathing.
The patient is minutes away from death. This is a sign of impending brain herniation. It is a surgical emergency of the highest order. You need to drill a hole or take off a piece of the skull immediately.
This is incredibly intense. It really highlights how fragile the system is when the physics go wrong. Before we wrap up, let's do a rapid review. We've covered a lot of ground. Let's talk about the common exam traps, the things that trip people up on tests and in the ER.
Let's bust some myths. Trap number 1. The CT was normal, so they're fine.
And the correction.
A normal CT does not exclude a concussion. Concussion is a functional problem. The software is glitching, not always a structural one you can see on a scan. You can have a normal scan and still be very symptomatic and need observation.
Good one. Trap number 2.
They are awake now, so they are safe.
The lucid interval.
Exactly. The extradural hematoma is a ticking time bomb. GCS can deteriorate. You cannot send them home immediately without a period of observation if the mechanism of injury was severe.
Trap number 3.
Focusing only on the head.
Tunnel vision.
Right. Never forget the neck. Cervical spine injury coexists with head injury. If you twist the head to look at the pupils and snap the spinal cord, you've done a terrible disservice.
And trap number 4.
Prioritizing MRI, because it's a better machine.
Right.
Correction. CT first. Speed is life. MRI is for later, once the patient's stable, and you need to look at more subtle injuries.
Excellent. Let's volley the top 10 takeaways for our listeners, just the headlines to lock this all in.
Let's do it. Number 1, head injury equals primary plus secondary damage.
Number 2, secondary injury is preventable. That is our entire mission.
3, GCS measures severity and, more importantly, tracks deterioration over time.
4, a GCS of 8 or less means intubate immediately to protect the airway.
5, non-contrast CT head is the investigation of choice in the acute setting.
Halfway there. What's number 6?
A lucid interval should make you think of an extradural hematoma, the lens-shaped bleed.
7, a subdural hematoma is a venous bleed, crescent shape, and common in the elderly.
8, hypoxia and hypotension are the absolute enemies. Keep blood pressure and oxygen levels up.
9, raised ICP causes Cushing's triad. That's high blood pressure and a slow heart rate, a sign of impending doom.
And 10, early aggressive management saves brain tissue. It's an active process, not passive waiting.
That is a powerful list. It really puts the management in clinical management. It's active, it's vigilant.
It is. It's not just watching and waiting. It's active protection of the brain, second by second.
So, to bring this all together, we've gone from the roadside accident to the ICU. We've seen the physics, the scans, and the pressure waves.
And the philosophy remains the same throughout. Protect the airway. Prevent secondary injury. Monitor closely. We are buying the brain time to heal itself.
It brings up a provocative thought for me as we close out. We tend to think of the skull as this armor, right? Evolution built it to protect us from clubs and rocks. But in the context of modern trauma cars, heights, speed, that armor becomes a cage.
That's a profound way to look at it.
The bone that is supposed to save you becomes the very thing that traps the swelling and kills you. The real battle isn't just the initial impact. The real battle is fought by doctors trying to manage invisible pressures and blood flows inside that fixed box. It really changes how you look at a simple bump on the head.
It does.
It makes you realize just how delicate the machinery of consciousness really is.
It is remarkably resilient, but terrifyingly fragile when the physics of the world go wrong.
Well, on that note, thank you for walking us through this. It's heavy, but understanding how the experts think makes it a little less chaotic.
Always a pleasure to connect the dots.
For everyone listening, stay safe out there, buckle up, watch your head, and we will see you on the next deep dive.